Afternoon, everybody. It's me again, Sunny Kelsey Lilico. I think in the interest of time, we should start. So we just wanted to say welcome for those of you who've joined us to today, which is our PPN Midlands 4th anniversary event. Next slide, please, Molly. So what we wanted to do this afternoon is share with you some of the achievements that we've had this year through PPM Midlands. Can't quite believe it's been in 4 years. And for those of you who've been with us from the start, thank you for your support. We were stepped up during the depths of the pandemic, so it's been amazing that collectively, with all of our members, we've been able to achieve the things that we've done. Today, though, we're also going to have a particular focused presentation that fits within our transform and innovate planets, and we'll come on to them in a bit later, specifically focusing on one of the NHS England workforce transformational projects, which has been the role of health psychology in an integrated care system. Next slide, please, Molly. So just a little bit of a background for you. So PPM Midlands, we like to shout about the fact that we are a diverse and complex region that has 11 ICSs. So we are coast to coast across the length, well, the width of Britain, of England. We cover one of the largest geographical patches. And as I said, we have 11 integrated care systems. And we have, I think it's 41 NHS trusts, but 39 of them actually employ psychological professionals. And when we did a paper earlier on last year, we were looking at all of the universities and higher education institutes that are within the region that have courses that are relevant to the training of psychological professional, we identified over 100. So it's amazing the level of talent and expertise that we have. And one of the joys of being chair of PPM Midlands is creating opportunities where we can forge connections to really start to make a difference. Next slide, please. So this is just a bit of a shout out to all of the work that the team are doing, and behind the scenes, you'll see Molly and James. Molly's our assistant psychologist who'll be sharing the slide deck and doing all the wonderful magical things with Menti, and James, who's our program manager, who many of you will also know and have contact with, will be monitoring the chat as well. So we'll have some time for some questions at the end. But just to highlight some of our achievements, so as a PPN, we now have over 2,500 members. If you want to join, please do reach out via our either through our handle there. I was going to say Twitter handle, it's an X handle, which always sounds a bit strange, or our email accounts. We have produced over 160 bulletins. If you haven't seen them, they're a great read. They're simple, they're short, and actually what they do is connect and highlight some of the key issues that are going on in the region that relate to the psychological professionals. We've also done some focus pieces of work that is actually about connecting integrated care systems with psychological professional leads, and that's achieved some really good outcomes. We're starting to see systems now that are talking about having faculties for the psychological professionals that are really thinking about how we can bring the psychological professions workforce into the thinking and psyche of health and social care leaders. For those of you that are interested, you can have a look on the website. We've got our workforce report that gave a first snapshot of our workforce across the whole Midlands piece. It's been a labour of love. I think James would attest to that, because it's interesting looking at the data that is and isn't around. We've also really leveraged our communities of practice. So we've just listed the number of communities of practice that we've got there. So for those of you that aren't aware, CPPO stands for Chief Psychological Professions Officer. Essentially, they're the most senior psychological professional typically within an NHS organisation. But we've got a number of communities of practice, and they are the vehicles by which we are connecting people up together to create change. We've also been developing a number of e-learning resources, so please do reach out. One of the most important ones that we've been really proud that we've been able to rescue, if you like, from some of the old legacy platforms within Health Education England and NHS England have been a skills into practice e-learning, which is fundamental if you are involved in upskilling and encouraging your workforce to take upskilling opportunities and then to apply them into practice. Really talks about, in bite-sized ways, things that you need to consider before the person even undergoes training. And we're in the process of finalising a psychological practice in physical healthcare fundamentals course. And we're hoping to be able to then launch that during Psychological Professionals Week, which is later on in November. Another piece of work that we will be launching at that time will also be our ethnic representation in the workforce, specifically our clinical psychology workforce. And that was a piece of research that we were involved with the BPS and the University of Birmingham that really talks about what our representation is as a profession and how that compares against the needs of people that access our services and the general population. We've also continued our role as professional advice givers, particularly to NHS England Workforce Training and Education Team, big title, formerly known as Health Education England. And we've had to date over 1,500 what we call critical friend requests and responses. We used to call these the let's call Sunny Corner. And it still is actually those times when colleagues will reach out with a question or a dilemma. And whilst we're not a professional body, we're a membership body, what we do try and do is actually support and guide and potentially coach people to take action where they need to take action. Another project that we're really proud to have commissioned is around connecting our Midlands lived experience leads. Tomorrow we've got a special face-to-face event that is connecting them up with a view to think about how we can create and empower a group of fundamentally driven individuals to really help us think about our psychological practice in a different perspective, with a different perspective in mind. And then our existing work streams. So that, we've done a huge amount, but if you want to know more and you're not in receipt of our bulletin, please do reach out. Next slide, please, Molly. I mentioned the planets at the start. So these are our guiding principles, if you like. There was a major piece of work that was carried out a couple of years ago now that really strove to understand exactly what our vision was as a group of psychological professionals. Because think about it from this point of view, up until a few years ago, the concept of psychological professions wasn't really well understood. Psychologists were understood, therapists were understood, but the idea that we could have a collective of over 24 now different occupational groupings under the family of psychological professions was unheard of. So the vision and the planets, if you like, are a way to create unifying stories, things that we actually have agreed to. And these visions and these planets have been generated from colleagues across the world, because actually we did have individuals contact us internationally to really think about exactly what was important if we were going to deliver our vision. And within PPN Midlands, we still use these planets to really guide the efforts that we are promoting, which is why today we're really pleased that we've got Helena to really help us think about the Transform and Innovate planet. Next slide, please. So thinking about Helena's work, one of the things that has come through the vision work with the psychological professions was a recognition that a lot of the early work that was being done was very mental health driven. And actually, we know that there is a systemic inequity in the way in which professional courses are funded in the psychological professionals workforce group. So we were really keen and wanted to provide some time today to really showcase a national piece of work that was commissioned formally through Health Education England as part of its workforce transformation program. We've put in that slide, there's a link to the actual initial website which talks about the project, but we've also put a link to Clinical Psychology Forum. There was a special issue that was published in April of this year, and within that there was a chapter focused around the workforce elements, and that particularly highlighted the need of consideration of psychological practitioners, or particularly practitioner psychologists, within physical healthcare settings that is broader than a traditional clinical psychology approach. I think one of the points I want to just say about this program, without stealing any of Helena's thunder, this was groundbreaking in the sense of actually being able to get NHS England to agree that there needs to be a refocused consideration of the impact of health and psychology within health and social care. And we reached out to Liz Jenkins and Lucy, who you'll meet a little bit later through the presentation, who lead the NHS England programme. And what they have highlighted so far of this scheme, and this scheme is essentially placing a health psychologist, a trainee health psychologist within one of the ICSs, within one of the 7 regions, and an ICS within that 7 region of England, to really think about workforce transformation. And Lucy came out with 3 really key points that I think I just want to highlight here. One, what they've recognised is just the achievement of connecting and using behaviour change within workforce initiatives. And these are the bread and butter of our health psychology colleagues, but actually using them as levers for change within workforce initiatives has been really important. Second thing that has been really important is being able to utilise health psychology and behaviour change to upskill others, and to really think about that within the different organisations that have agreed to host each one of these trainees. And also, one of the things that Lucy highlighted is that we're starting to see the retention of skills within the NHS beyond the programme. And that's really important, because actually what we're wanting to see is for trainees to actually have active roles within health and social care in the longer term, so that the skill set that they have, the unique contribution from a behaviour change perspective, has some real traction for us. So I urge you to have a look at Clinical Psychology Forum. And what I'm going to do now is hand over to Helena, who's going to take us through her presentation and really share with us all of that learning and the great work that she's been doing here in the Midlands in Derbyshire. Helena, over to you.
Thank you very much for that introduction, Sunny, and thank you very much for inviting me to talk. So you've introduced me very well. I don't feel like I need to say much more in terms of that. But yeah, I'm a trainee health psychologist, and I'm funded through NHS England to work on projects relating to workforce transformation and redesign. Are you okay to go to the next slide, please, Molly? Thank you. So today I just wanted to talk to you all a little bit more about kind of health psychology, the training routes that existed previously, and then the new NHS funded route that I'm on, a little bit more about my work as a summary, and also one project in slightly more detail, just to give you a little bit more of an idea on the work I've been doing, and then just provide some reflections really on the programme from myself and also from my supervisors. Can you go to the next slide, please? Thank you. So health psychology is fundamentally the study of psychological and behavioural processes in health and illness and healthcare. And it's simply put kind of what we think, feel and do about health. Next slide, please. So where do health psychologists work? So currently they work across kind of primary and secondary and tertiary care settings in a range of different healthcare settings. They're involved in areas such as large-scale public health programmes, also down to kind of conducting individual or group consultations with people, or working within academia as well, so potentially doing things like teaching and researching in areas of their expertise. There's approximately 610 health psychologists in the UK at the moment, and around 1 in 6 of these are employed directly by the NHS itself. Next slide, please. Thank you. So this diagram is of the current training routes that exist across health psychology within the UK, and they're similar to other kind of applied psychology training programs as well, in terms of that kind of initial undergraduate bachelor's degree, and having sort of 7 years specialist training, sometimes more in other areas. So you have that kind of undergraduate degree in psychology as that starting point, and then the stage 1 is your master's in health psychology, which you need for most of the next routes. You can see there route 3 says that it's now open to those with or without stage 1, but for most you need that undergraduate degree and then the master's, and that provides that kind of knowledge foundation to then go on to that doctoral level training, which has these 3 different routes that are outlined there, and they take usually between kind of 2 to 5 years, sometimes more, sometimes kind of less than that 5 point, but 2 is usually the minimum through the BPS or professional doctorate route. And funding for these has usually come through kind of people's workplaces, people funding them independently rather than it being funded through the NHS previously. So there's funding for a small number of trainees per year through NHS National Education for Scotland. That's been running for many, many years, and it's made a considerable impact on health and care transformation and opportunities for health psychologists within NHS in Scotland. But until now, there's been no such funded route in England. So this is the first, like Sunny mentioned, the first programme that's run that's been funded by Health Education England at the time, so now NHS England, and there is one trainee in each region of England, of which I'm very gratefully the Midlands trainee and was very lucky to have this position. So this is almost that kind of first initial pilot programme of how this runs, and to test out how it works to hopefully see if we can implement this again in the future. So the NHS route follows that route 2, that middle one in the yellow, where you have the undergraduate degree in psychology and then a master's in health psychology, and then the stage 2 training starts at a band 6 role within the NHS, and then a newly qualified would then be able to start within the NHS at a band 7. But again, it's kind of next steps are then decided by the trainee and the opportunities that are out there. But if they were to stay within the NHS, hopefully that would then be a band 7 role within that. Are you okay to click on the next slide, please? Thank you. So a little bit of background then about kind of why they wanted to create this programme and what they were hoping to achieve by it. So it was established by Health Education England to build on workforce redesign capability and capacity using psychology of the system and behaviour change to benefit staff, patients and organisations. So, for example, through things like embedding effective new ways of working, and it aimed to kind of integrate health psychology trainees within organisations to test the impact and effectiveness of this programme and of this work, to see if we could run this similarly to how it's been running within Scotland previously. I will say that the way the Scotland one runs, it isn't focused on a specific area. So the fact this one's funded through workforce transformation and redesign is also a very new thing, separate to the Scotland version as well. That was something that was kind of new to this as well. They wanted us to use evidence-based tools to understand behaviour change and develop sustainable interventions. For this, we were asked to use the COM-B model and behaviour change wheel to support in workforce redesign programmes. They also wanted to build on behavioural science and the capacity for that within different regions. So building on that capability for people to use behavioural science methods and practices in different areas where they were maybe not being used before. For example, some people were working in areas that maybe didn't have health psychologists currently working in. I myself was in a health psychology department, which was really, really lovely and supportive. But again, other people were able to kind of bring health psychology to an area where it hadn't been previously kind of thought about or used before. Are you okay to go to the next slide, please? Thank you. I don't have a huge amount of time to kind of go into all these names of different people who were on the steering board and all the fantastic work that they did to kind of get this moving and get it into place. But I just wanted to kind of have this slide here so that if anybody wants to look back at the slides, they can see who was involved. Elizabeth Jenkinson, who Sunny mentioned earlier, is the National Training Director and is at the bottom of that slide. And then Lucy Renwick, just above that, is the Workforce Transformation Lead. And they're both really, really useful people to contact. So if anybody's got any questions for them, I'm sure they would be more than happy for you to get in touch. Next slide, please. Thank you. So I wanted to talk a little bit about this idea of workforce transformation and what this means in terms of kind of this programme specifically. So transformation is a process of profound and radical change that takes an organisation in a new direction and to an entirely different level of effectiveness. So in terms of within the NHS, there were kind of 5 key enablers of workforce transformation, which were outlined. And these were supply, upskilling, new roles, new ways of working and leadership. If anybody's ever looked at the HE star, it maps these out in like 5 nice points. But again, just to kind of give you an example of one of them, The upskilling one is an area that I've done some of my work within that I'll talk about later. And it's about kind of upskilling the workforce to be competent and working to its full potential, making sure they're agile and can be deployed flexibly, and have kind of future facing knowledge and skills. So not just thinking about the here and now, but also thinking about the next steps in prevention. Are you happy to go to the next slide, please? Not used to having to say next slide, please. In terms of my qualifications specifically, the BPS requires that you meet 5 competencies. So these are professional skills, research, psychological interventions, consultancy, and teaching and training. And we were put in place and funded for 2 years of full-time work within the NHS. So I personally have been doing that work within Derbyshire Community Health Services NHS Foundation Trust. And like I said earlier, we've kind of had, as our 7 trainees, a little bit of a different experience of going through that BPS route, in that we've kind of had work that we've kind of had to find work that matches those 5 competencies and covers those, but also focuses on workforce transformation and redesign. So we've had to kind of try and match things up with what the NHS trust that we're working in needs, what the BPS needs us to do, and also what workforce transformation goals we can kind of work towards. So I've kind of imagined it, and we all kind of have, as this kind of Venn diagram of some stuff sits within each of those individually, and lots of it then overlaps as well. So it's kind of had those different elements to it. On the right, you can see my coordinating supervisor is Dr. Helena, who's a principal health psychologist, and my workplace supervisor, Dr. Jo Hall, who's a principal clinical psychologist. Next slide, please. So I asked my supervisors before doing this talk a little bit about kind of why my organisation saw value in taking on a health psychology trainee, so that I could then kind of feed that back as well as to why they chose to do this and chose to get involved with the programme. And these were their sort of main points. So they wanted to support the development of the health psychology profession. They wanted to gain from the expertise and experience of a trainee health psychologist. They wanted to learn about the experience of hosting a trainee health psychologist. They wanted to learn about the value of a health psychology trainee and what they could add to the workplace. And they wanted to play their part in expanding the psychological workforce, and wanted to benefit the NHS workforce too through that additional psychological capacity and having another kind of psychological professional within the team. Next slide, please. So I wanted to do a bit of a summary of some of the work that I've been doing, just to give you an idea of kind of what's expected within this training programme and what some of the work might look like. I haven't mapped out the professional skills competency for this one because it's sort of one that's worked on within each of the other competencies. So I've not outlined it as anything specific. But again, things like delivering talks, trying to kind of spread awareness would all come within that kind of professional skills one as well. So for my research project then, we need to do a systematic review and an empirical research project. I've done my systematic review on the effectiveness of, I'm doing it as we speak, the effectiveness of workplace interventions for people experiencing the menopause, their colleagues and managers. And I'm doing this because I did a health needs assessment survey, which went out across Joined Up Care Derbyshire, which is our integrated care system in Derbyshire. And that found that 42% of staff felt that their health was currently affected by the menopause. And 60% of those then said that it impacted on their work. So I felt like it was a really key area to kind of have a look at. And then similarly to that, I'm doing my empirical research project within financial concerns in health and social care staff. So looking at kind of how those concerns are impacting on staff health and wellbeing, the kind of support that they might want to see in the future or that they've found beneficial. And again, the quantitative part of this was that health needs assessment survey, in which I think it was 1 in 3 told us that they had current financial concerns. And then I'm going on to do qualitative. My qualitative section of that will then be semi-structured interviews to get a little bit more in-depth information from them. And then my psychological interventions, I've done my individual client work through Resolve, which is a staff counselling service. So taking on clients who have a physical health condition or symptoms that have been impacting on their mental health, or those wishing to kind of make a healthy behaviour change. And then for my group interventions, I've been doing a couple of sessions around the menopause and things around kind of looking after your health and well-being and talking to important people in your life. And then the consultancy one has been with the Quality Conversations training program, which is the one that I'm going to be talking a little bit more about in detail. And within that, it's led to me doing these Quality Conversations masterclasses, which has helped kind of me also meet my teaching and training competency alongside kind of delivering some other sessions around reflective practice and behaviour change training and things like that. Next slide, please. So the one that I want to talk to you a little bit more about was kind of the work that I've done with the Quality Conversations training program around thinking about what happens beyond the training course and how we support integrated care system staff to implement quality conversation skills into their practice. Next slide, please. So just to give you a little bit of background so it makes sense on the Quality Conversations programme, it's a training to support effective conversations, and it's Derbyshire's version of Making Every Contact Count. It's focused very much on reducing health inequalities, how we can improve access and effectiveness of healthcare, and it's currently a 3-hour online training session that, again, goes out across Joined Up Care Derbyshire, and one of the other objectives that I've been working on, so I've worked on kind of 3 objectives with the Quality Conversations programme underneath my consultancy project. One of those were around kind of helping to develop and provide feedback on some of the additional spotlight sessions that they've then gone on to create, which are optional for people to attend. So around things like behaviour change, mental health, self-management, leadership and health literacy. Next slide, please. But I'll be talking about a slightly different objective in today's kind of talk, and that's around this idea of skill implementation and how we get people to take that learning from the classroom almost into practice. So we know that there's often an implementation gap where learners struggle to implement continuing professional development course material into practice. Previous research into Making Every Contact Count has shown that healthcare professionals did not deliver behaviour change interventions on about 50% of occasions where they perceived a need. And again, that's ones where they've perceived that need and it's still only really being delivered on 50% of those occasions. So we know that it's hard for people to actually implement these training kind of packages and the training that they've received into that practice. Some of the barriers to implementing MEC were things like lack of time, training, confidence, evidence of its effectiveness and perception of it being someone else's responsibility. And this linked with 8 different sections of the theoretical domains framework around environmental context and resources, beliefs about capabilities and consequences, knowledge, intentions, skills, social professional role and identity, and emotions. And we know that behavioural science improves the effectiveness of interventions. Next slide, please. So my kind of purpose with this was to support learners to implement their learning into practice and to do this in ways which were kind of behavioural science-based interventions. So the way that we kind of went about this and I decided to kind of do this were to create QC masterclasses and also to create training and resources to the peer coach network. And I'm going to talk about that in a little bit more detail now. Next slide, please. Thank you. So the Quality Conversations masterclasses were shared group learning and reflective practice style sessions, which were focused on a key skill or area. So for example, Quality Conversations talks a lot about kind of communication styles and whether we're in push or pull communication, and pull would be that kind of asking open exploratory questions, being kind of strengths-based, learning to understand rather than respond, all of those things. So we did a session, for example, on pull communication and thinking about maybe times that we slip into push where we want to be in pull. And these sessions that were delivered were open to all Joined Up Care Derbyshire staff who had attended the core training at least 4 weeks before and had time to then have a go at practicing some of these skills. I also ran bespoke sessions for specific services on request. So, for example, there were some community teams who had a lot of physiotherapists and occupational therapists who were struggling to have conversations around equipment and it was those difficult conversations around kind of what they could and could not provide in terms of those pieces of equipment and how they go about doing that, and having that kind of shared reflective session within that servicing group. And the sessions followed a similar kind of structure in terms of having a little bit of a recap of that skill that we were covering, or that conversation that we were kind of talking about, and then thinking about strengths. So what's going well, what are people doing well, because I think that's an element that's often kind of forgotten with this. We go to kind of what's not going well rather than kind of actually thinking about what are we doing well and what's going right. On to then talking about some of those real life challenging scenarios that people were facing, and then doing a little bit of that group problem solving. So thinking about, has anybody else had a similar experience? What have people tried? What's worked? What would people want to do differently next time when they had that kind of conversation before? And we had 97 people attend the Quality Conversations masterclasses in total. And we were really, really happy that these reached kind of the 8 sectors within Joined Up Care Derbyshire. So we had people from NHS, we had people from the council, we had people from the voluntary sector. And yeah, we were really pleased with that kind of reach across, which was similar to that Quality Conversations training itself. Next slide, please. And in terms of the peer coaches then, so the peer coaches are a group of 75 individuals who are a supportive network of quality conversation champions. We ideally aim for kind of 1 to 2 people per team, depending on the size of the team. I want to say as well, this was a group which existed before I came to work for the Quality Conversations programme. And that kind of came about because I realised that the Quality Conversation masterclasses were only really viable if someone was there to facilitate them. And I knew that my work as a kind of consultant on the programme meant that it was short term. I was with the programme for a year, and I wanted to make sure, thinking about that kind of new ways of working and that kind of sustainable approach to interventions, that actually there was something that could be continued after my work finished. They were hoping that potentially they'd be able to carry on the Quality Conversation masterclasses, but at this point we weren't sure. And I'd also kind of read about from that kind of MEC research that people wanted this approach to be integrated within staff culture and not viewed as an add-on, and they wanted that kind of infrastructure around them to support them to do this. So I then took the approach of training the peer coaches in behaviour change, creating resources for them that were then passed on to the peer coaches, and creating things like lunch and learn session guidance so that the peer coaches would be able to facilitate quality conversation masterclass style sessions with their own teams then, so that there was a way that they could continue. Next slide, please. So in terms of how these approaches linked into the COM-B model, I've mapped out a few key points. So I won't go through all of them, but for example, under social opportunity, I wanted to try and make using quality conversations the social norm, and I hoped that kind of this peer coach, using the peer coaches and the quality conversations masterclasses, would help encourage people to kind of see others who were using quality conversations, others who were kind of trying to use quality conversations techniques, to kind of increase this concept of it being within everyone's social professional role and identity. Similarly, if the peer coaches were then able to go back and deliver these kind of lunch and learn sessions or pass these resources back onto their team, again, it's creating that concept that it's within their role, it's within their identity, within their teams, to kind of think about quality conversations and build it into their kind of everyday conversations. Another example being the psychological capability one. So I hope these methods will kind of upskill people, especially through the quality conversation masterclasses and the sharing of kind of strengths and that kind of group problem solving, to show them that, you know, others have managed in similar situations and have ideas of what else they could try. And again, in that peer coaches, it's almost like empowering people that their team has the answers. If they have these reflective practice type sessions, you know, they're able to kind of learn how to implement quality conversations more effectively within their own teams as well, without even needing the help of someone external. Next slide, please. So in terms of feedback, we gathered qualitative feedback from the peer coaches in feedback forms and emails, and we gathered quantitative feedback from the Quality Conversations masterclasses at pre and 6-week post session on knowledge, confidence and COM-B measures. And the reason for that is we wanted to actually be testing for whether there was a change, rather than people saying that they felt like they'd be more confident, or that they were going to implement it. We wanted to see if they felt like that change had actually happened, and had been more sustainable. And then we gathered qualitative feedback as well, which was gathered immediately post session, which again was more like the classic, what did you like least, what did you like most from the session, and that kind of information. Next slide, please. Thank you. So in terms of the quality conversations masterclasses, we found that people really valued that learning and refreshing knowledge, the concept of kind of overcoming barriers together in this kind of reflective and supportive session with other people around who had similar kind of aims and similar interests as well. And then for the peer coaches, it was things around being able to network with other people, learning about other services, sharing best practice, and that kind of reflecting to understand as well. And then looking at that right-hand side, that's the quantitative findings for the QC masterclasses. So as you can see, there was a positive increase on knowledge, confidence, and all of the COM-B measures, even at that 6-week post-session delay form. With reflective motivation at the bottom, in the middle there being kind of 5 out of 5, and even the automatic motivation, so people feeling like they were doing it out of habit and without even thinking, had gone up to kind of 4.6 within that. Thank you. Next slide. So a little bit of a kind of discussion then on this specific area of work. So some of those strengths were, the initial findings were positive. It showed positive kind of changes within that knowledge, confidence and COM-B factors, which I wasn't anticipating that they would all be increased. So I was very pleased with that. It's also a really important topic area. So I think, obviously I work within the NHS, but I know it's the same for lots of integrated care system kind of wide organisations, that we have as staff a huge amount of training, but actually being able to kind of ensure that that training's implemented into practice and seeing what we can do to help staff to be able to do that is really, really important, to make sure that it's not just kind of an e-learning or a training that's kind of ticked off and you put it to the back of your mind and you feel like it's done. It's kind of, how can we continue to build on that and ensure that we are getting these really important topics actually into people's professional practice. In terms of it being integrated care system kind of wide training, that was really positive, and that allowed for kind of the sharing of knowledge and experiences across teams. I think it increased people's compassion towards other services and other staff members, in the fact that they were very much, oh, okay, like we tried to make a referral into your team, but we weren't able to. But then people were realising the stress and pressures that other team were under, and a little bit more about kind of what that team's scope were. So there was some conversations around that, which were really positive. And it also improved those links for partnership working. So where some people might not have known that a service or a voluntary organisation existed, it was able to kind of also highlight what else is out there for people. In terms of the limitations, so more data needs collecting for robust evaluation. So it was an incredibly small sample in terms of those feedback mechanisms, and getting people to respond to that 6-week post delay was challenging, which means we're unable to test for significance at this point in time. So we still need to kind of continue to collect data. There was also quite high dropout rates in some of the sessions, especially from clinical members of staff, where they'd obviously signed up to this wanting to come, but it being kind of a voluntary extra. And sometimes kind of clinical need means that other things come up and people have to drop out of sessions. There was also some challenges with kind of low virtual engagement. I think in kind of modern society now, and it being lots of virtual sessions, it does come with some challenges, especially in a reflective practice type session, when you've got some people who are contributing loads and other people have kind of got the camera off and just want to listen, and you're trying to encourage people to kind of learn from each other in that group. So that was a little bit challenging at times. And the integrated care system wide training, those kind of open sessions which were available to everyone, did pose some challenges in terms of from a facilitation perspective, just from the fact that it was very much about kind of hearing somebody's challenging scenario and trying to like pick out the theme, the quality conversation skill that might have been more challenging or more difficult, and trying to kind of open that discussion out, but in a way where it's not so specific to that area of work and that person's example, that other people felt like they were able to kind of contribute. So I think although it came with some challenges, everybody seemed to kind of be very positive in their feedback, and seemed to be kind of finding it beneficial, this kind of approach of doing these open reflective practice sessions. Next slide, please. Lastly, I just wanted to kind of take a little bit of time to reflect on the training program and some of the strengths and challenges in terms of the pilot program that I'm doing this training under. So I've kind of had a conversation with my supervisors about this, and we've kind of agreed that these are some of those kind of strengths and challenges in terms of the kind of key, probably main points. So in terms of those strengths, it's very flexible. So the remit allows for kind of shaping the placement around service needs and also trainee strengths and areas of development. So there's lots of flexibility. There's a longer placement than with some other kind of training programs, and that's kind of helped. We think that helps the trainee to kind of integrate into the team fully. It's also quite easy to then match those 5 competencies to work opportunities. So they're quite broad. So research, consultancy, they're quite nice in terms of being able to find opportunities that fit. It's been quite useful to have an academic lead for the trainee separate from the placement lead. The team said that they've valued their additional colleague for the 2-year period with their kind of range of adaptable skills in teaching, training and service development. So being able to have that kind of additional capacity for work. And then in terms of challenges, it's a little bit unclear at times of how much placement time should be allocated to things like write-ups, especially if they are something that benefits the service specifically, rather than just something that the trainee needs to do for their qualification. It's been challenging at times to keep kind of academic tasks active in a fast-paced NHS environment. So things like trying to keep research active if it's going on for that 2 years, when the NHS looks for kind of wanting responses and kind of answers and investigating things at kind of more of a fast-paced level. And just thinking about that kind of difficulty to retain trainees post-course due to lack of kind of workforce transformation and redesign roles within psychology and within the NHS. So thinking about kind of how we've been set up within this training and whether there will be positions within that kind of workforce transformation area, or positions kind of elsewhere as well. So yes, that's everything from me. Thank you very much for listening. I'm happy to kind of answer any questions.
Wow, Helena, thank you so much. And colleagues that are on the line, we will share the slides that are available afterwards. I wasn't sure whether we're going to take questions first before Menti. James, do you have some advice?
I guess getting feedback through Menti while we're also taking questions is maybe a way to go. And certainly I've got a question, if I can cheekily ask first. I know we've got one from Paul Lawson, which might be a broader question. Paul always poses us very challenging questions.
I've got 3, James. So if you go for your question, and then colleagues, whilst we're doing that, the reason that we've got the Menti up as well. So the code is in the chat, but if you want to provide some of the feedback there, we'll show that as we go along. But if you want to go with your question first, James.
Yes. So, Helena, I was wondering about resistance to change themes within the quality conversations workshops that you had, and also with the peer coaching sessions as well. Were there any particular themes that you had?
I think I was incredibly lucky, to be honest, that as the sessions I ran were kind of voluntary, people chose to come along to them. We've had a little bit more, I would say, as a program, and I would say that's more kind of other people working on that as well before I kind of got there, but thinking about how we make the core training more accessible for people and kind of reduce that resistance to training, because the core training is more of the one that I would say we try and get everyone to come along to. And again, that started out at kind of 2-3 hour sessions a month apart, and has kind of been changed then to that 1 3-hour session, and then the additional optional spotlight sessions. So I guess in terms of resistance to change, it's been a lot about understanding that the workforce are under a lot of stress and pressure, and that time is really, really difficult for people to be able to kind of give up their time and come along to these additional training sessions. So it's been a lot of how can we make our service and our training most accessible to the people, if that makes sense.
It does, yeah. Thanks.
That's great, Helena. I think one of my questions, and I think you highlighted this in your limitations bit at the end, it's about what's next, because there is that challenge, isn't it, to have had this real opportunity for people within training roles to come into a service areas. And I think some of the dilemmas that you highlighted, I wonder whether there's some learning from clinical and counselling doctorate courses as well, about how you manage job planning and that navigation about what are you doing for your academic programme versus actually where's the benefits return for the service that's hosting you. I think there's some learning there. But next steps, what do you think's going to happen?
I don't know. Is this in terms of kind of my personal next steps or the program's next steps?
Both,
okay.
Actually.
Okay, so my personal next steps, I don't know. I'll be completely honest. I think similarly to a lot of the other trainees, I don't think any of us anticipated that this funding programme was going to be created and that we were going to manage to get onto it. So I think lots of us feel like we're in a position that we never expected to be in, and we're all kind of very incredibly grateful for that. But it's I can't say I've been like, I need to go and do this next step. I've always kind of wanted to do this training. I just thought it would probably be something that happened later in life for me. I think there's challenges in terms of lots of jobs are within clinical settings, even though they're kind of often within health related settings, they're still clinical. So things like tier 3 weight management services or kind of oncology services, lots of them want people with a bit more clinical experience, I would say. So I think it's just how we then take this kind of next position or next role, if we want to get into clinical settings, to try and gain a little bit more kind of active work experience. But again, I'm kind of stuck between the fact I love this kind of strategy, this kind of more service level intervention work, but I also have enjoyed the clinical work. So I would be happy with either, which probably makes my job easier in terms of looking for jobs. But yeah, I think lots of people have said to me, it's that kind of first job that's often the hardest to get, that kind of foot in the door after the qualification that's challenging. But everybody's been very nice and saying, once you're there, you can keep going, and it's really great, and it's a great area to work. But yeah, I think it seems to be that kind of first step that's the hardest. In terms of the programme next steps, I feel like Liz would definitely be the best person to kind of answer that. I think she's been incredibly keen for it to be something that continues, but I think at this stage, as far as I know, nothing's kind of been confirmed for kind of later cohorts. But I think the aim would be to hopefully show the effectiveness of the programme and hope that it would continue like it has in Scotland every year.
Yeah, and I think some of the feedback that I think I highlighted at the start that had come from Lucy was that what we're starting to see is some traction of those roles developing into into NHS services as well. And if I literally take my chair of PPN hat off and I put on my Chief Psychological Professions Officer for a big NHS organisation hat on, there's some real appetite about how you actually can diversify that practitioner psychologist workforce, particularly in areas that are to do with physical health care. When we are looking at behavioural change, I mean, one really obvious thing that comes to mind for me now is, if you think about the season we're in, every NHS organisation or statutory service is in the midst of a flu campaign. And one of the really basic things is actually where are our our behaviour change elements there? How are we supporting from a capability, opportunity, and also motivation perspective to start to leverage some of those changes.
Yeah.
And I think there feels like there's some missed opportunities.
Yeah, I totally agree. Yeah, I think we do kind of forget sometimes about within kind of wider healthcare settings of we kind of want to deliver a message to people within the community or services, but we sometimes forget about how important the wording is of that, and kind of whether we're going to get people to actually engage in what we're saying and, you know, actually take up what we're kind of advising as well.
Great. I think I'm not sure, Molly and James, if there's anything that's coming through on the Menti, or I know we've got some themes that have been put there, and I know Paul Lawson from one of our experts by experiences, I think posed some questions that I think are probably more broad than we necessarily can handle today. But just looking at what's coming through, there's some really I can't quite see, Molly. The screen's got the QR code right in the front of it, so. Let me just see if I can move that away, but I can't. So if we could go to the top and we'll just have a look and see some of the things that are coming through. So it's really informative, sounds really interesting. There's one there, useful to understand the potential of health psychologists and the current driven training. I think that slide was really helpful. That's one of the things I think we want to really showcase and share. I noticed a question there. Oh, thanks, Molly. If you could scroll down slightly, Molly, there's a question there. So
there's a question
Helena.
also in the chat, sorry, from Alison Bryant regarding service level and how much service user / expert by experience contact did you have or would have been useful to you?
I think this is another element that's quite interesting to explore in terms of the workforce transformation element. So I did my kind of psychological interventions work with staff. They were staff who had kind of personal challenges that they'd come along for, rather than it being kind of workplace stress. But I've noticed a lot of people are still kind of feeling like that's staff still and not kind of service users. So I think in hindsight, some specific clinical experience with kind of patients or service users would probably have been preferable going into kind of the next steps and career opportunities. It's kind of a fifth of our time in terms of it being kind of 5 competencies, but it's been very varied depending on the area that people have worked in, how many referrals those services have been able to have that have been appropriate for that health psychologist. So I would say, again, that's something that's been really, really different for each trainee. There's no specific thing of you have to have this amount of kind of clinical experience or this much experience with service users. So I think that's something that would always be kind of spoken about with the organisation, and very much kind of has been kind of altered depending on supervision as well. So if your supervisor's been happy with your kind of clinical practice, it might mean that you've done less, but actually if you've been struggling more with that, it might be that you've taken on more clients, more service users, so that you can get more experience if that's something that you need to work on.
Thanks, James, for highlighting that. I think, Molly, do you just mind nudging the slide down? Because I think I was reflecting also as you were talking, Helena, that it does seem very similar to the position of counselling psychology. And we know that there is systemic inequity in a lot of the professional training programs, that only some are funded centrally and a lot aren't. So I think it's just really important that we're able to take some of this learning, because I think what you've also just highlighted there is a lot of it seems to be self-directed or dependent on the services in which you're able to get a placement. And from my point of view, I know we've got Lawrence here from the BPS, but from my point of view, that feels a bit, places us in quite a vulnerable position, because we can't guarantee the overall set of competencies that people are coming through. Or maybe I phrased that wrong. We can guarantee the competencies, but we can't necessarily guarantee the experiences that people have had that will then allow them to move into a clinical setting or a academic setting.
Yeah, I guess in terms of kind of making sure that has been achieved has been kind of having these kind of supervisors. We each have kind of 2 supervisors that supervise our work, and also kind of the training program itself, and then also kind of keeping those logbooks, everything that's kind of checked with the BPS then when it goes through, to make sure that we have had enough of each of those kind of experiences and practice within that. Would be the only thing I'd kind of say on that.
Yeah, I think those are those opportunities, aren't they? But I think there still needs to be a piece of work that's maybe done with organisations as well that truly understand the skill set of a health psychologist, and actually is this a skill set that could really make a difference for service users.
I think I was very lucky, to be honest, being in a health psychology team, because I felt like I had a lot of that support and a lot of that understanding of what was needed. But I do think other people were in slightly different areas and potentially had less support around that.
Yeah, I think that's a great and actually I think you were particularly fortunate in actually having Helena and Joe and that infrastructure around you. I'm noticing the time that we've got, so I think we've done a refresh hopefully on the Mentee. What we'll do is if it's okay with you, Helena, we'll get these questions over to you, and it would be great if you felt able to either respond to those specific ones, that if there's noting that they are your individual reflections, and then what we'll do is make sure that when the slide deck goes on the channel, we'll also put the sort of information there in relation to your responses. But I just wanted to say a huge thank you. It's been really inspirational hearing you, and I hope that the colleagues that have joined, some people are dropping off, diving off to their 4 o'clocks, I'm sure. But thank you so much for taking the time and helping us really showcase the work of health psychology. And for colleagues on the call, just stay connected with us. There's our email address. We've got a nightly bulletin. And we've got a range of communities of practice that are focused around the different psychological professionals. And we've actually got one focusing around physical health care as well. We'll be showcasing some of our work around the Midlands sessions during psychological professionals, so keep your eyes peeled. And if there's any more information, please do reach out to us, and we'll be happy to support. But thank you for your contributions. Take care. Have a great day. Bye-bye.